And so that's ultimately what we try to replicate with the tool that we built. So this is the start of us using a multi-agent approach where AIs talk to one another. So in addition to this AI therapist that the user would be engaging with that facilitates the Socratic dialogue, the AI therapist was then supervised by another AI that would monitor the dialogue and provide suggestions for how to improve the conversation between the AI therapist and the user by just giving the AI therapist feedback in the background without the user knowing this.
Hello, and welcome to Season 2 of Beyond the Couch, AI in Psychology. I'm your host, Dr. Ernest Wayde. Now, as always, before we get started, I want to thank the organizations that make this podcast possible. This episode is sponsored by the American Board of Professional Psychology, the National Register of Health Service Psychologists, and my consulting firm, Wayde AI. Their support helps us create thoughtful, psychology-focused conversations about how AI is shaping our field. All right, now I'm very excited to introduce today's guest to you, Dr. Philip Held. Dr. Held is a clinical psychologist and associate professor at Rush University Medical Center, where he serves as the Director of Research and Innovation at the Road Home program. His work focuses on improving treatment outcomes for PTSD, especially for individuals who don't respond to standard approaches. He is leading multiple clinical trials exploring accelerated treatment models and new ways to personalize care, including the use of machine learning and AI. His team has also developed a multi-agent AI tool designed to support cognitive restructuring through Socratic dialogue alongside evidence-based therapy. Philip, welcome to the show.
Thanks for having me. I'm excited to be here.
I'm really looking forward to this discussion. But before we get started, I always like to start by asking, can you tell us a little bit about yourself, your work, and the journey that led you to AI, including those experiences that really shaped your perspective?
Yeah, happy to. It's not a linear path to AI at all, but I think it's one that'll probably resonate with several of your listeners who are in the psychology field. So, backing way up, I always known that I wanted to study military psychology and figure out how do we improve existing treatments for post-traumatic stress disorder. I knew this since high school, and I've pursued a super linear path in that direction. And so I've now have the pleasure of leading a program, the Road Home program, that focuses on exactly that, is providing now accelerated treatment programs for people or treatments for people with PTSD, where we basically take existing evidence-based treatments and deliver them in 2 weeks or 1 week and now even 2 days to those individuals with the same great outcomes that we normally see for traditional weekly psychotherapy, but in a much more accelerated fashion, which with much higher completion rates. And so that sort of led me to get really deep into the treatment of PTSD. And so how all of this led to AI is in two different forms. One is we saw that people would respond really well to these treatments, but about 1 out of 4 veterans doesn't. And so that was sort of the first time we played with AI as a possible solution of, can we leverage some of these newer technologies to help us determine who those individuals are, catch them early, and then do something for them that makes them ultimately a treatment responder. That's sort of like where we started with this in maybe 2017, 2018. And so where we really got into AI that we're currently talking about, which is the generative AI space, is much more recently, about 3 years ago. And this is in response to feedback we got from veterans. We're using cognitive processing therapy. We know it's highly effective, and we know that homework is highly effective as part of cognitive processing therapy. And we know at the same time that a lot of veterans don't like to complete homework worksheets. And so 3 years ago, really before ChatGPT 3 really took off, we were aware of that technology, but it wasn't really widespread. And so we were wondering, can we actually leverage these emerging technologies, in this case, large language models, to replicate one of the processes that we're asking people to engage in, which is the completion of homework worksheets, really to facilitate cognitive restructuring. But can these tools make it a lot more engaging for individuals than just sitting in front of a static worksheet while they're completing their practice? And so that's really the origin of this tool that you mentioned in your introduction, Socrates, which is now Socrates 2.0. And that's really what started our deep dive into this space. So that's a little bit about me. This is how I got to this generative AI base, but it's maybe not as linear as coming from a computer science background, which I do not have. I'm a treatment outcomes researcher by background and by passion. So it's really figuring out how do we use these technologies to help us further improve treatment outcomes for ideally individuals with PTSD.
Yeah, I actually really love that story and that line, the line that you've drawn there, because what you're really talking about is how AI, very often we talk about it from a clinical point of view, how it can be dangerous, and how there's a lot of fear based about it. You're really talking about how it can help veterans in a very specific way. So take us into that interaction. How is AI interacting in that PTSD treatment? How is the veteran responding and using that application?
Yeah, happy to. So when we started developing our platform, which we now call Socrates, and it always had that name, we in the early days built a very simple tool where an LLM would engage with the user by asking Socratic questions. And so I think most of you users will be familiar with the Socratic process. It's a very common approach in cognitive therapies, but why we chose this is that back in the day when LLMs were just sort of emerging, they weren't nearly as big as they are now. They weren't nearly as capable as they are now. And we wanted to think of what is an intervention that can be delivered by these tools that doesn't require a huge set of knowledge. How can we essentially leverage technologies at that point in time to facilitate some sort of change that is engaging enough for users? And this is why we picked Socratic dialogue as a way, because as a provider who uses Socratic dialogue, really all of the knowledge I need to have about you as my patient is
Mhm.
coming from your responses to my Socratic questions, right? And so every response you give me, I can use to form a new Socratic question to further advance the conversation and ultimately help you change a set of beliefs that you might want to be working on. And so we started there and used an LLM, an early LLM, to basically facilitate this. And we were really surprised because they functioned really, really well. They performed great in delivering Socratic dialogue. But what we quickly noticed is that as conversations would go on, they would engage in what we call looping. So this is essentially asking the same question over and over and over again.
Mhm.
And while this can be a little comical in sort of like everyday use, when we think about this in the sense of mental health treatment, it can be quite distressing to individuals if I'm asking you, what's the evidence for and against this belief that you have? And you
Mhm.
share this with me, and then I say, great, what's the evidence for and against this belief that you have, right? It can be really distressing to someone who's working on something that's really core to them.
Yeah.
And so
Yeah.
we needed a way to get around this. But this was also not the first time we've heard this. When we work with a number of our trainees, we see this. They pick up one or two questions that they really like and they use them effectively, except they then can't think of what's the next best question I should be asking. They sort of get
Mhm.
stuck on that single
Way to go
question.
from there. Yeah.
Yeah, exactly. And so basically based on this, we wondered, can we just replicate exactly what we do with our students in this case? And what we do with our students is we give them supervision. Either we give them supervision after the session, or in some training programs we have the bug in ear technology where
Mhm.
supervisors watch the session and they say, hey Ernest, why don't you try asking this type of question and see where the conversation goes. And so that's ultimately what we try to replicate with the tool that we built. So this is the start of us using a multi-agent approach where AIs talk to one another. So, in addition to this AI therapist that the user would be engaging with that facilitates the Socratic dialogue, the AI therapist was then supervised by another AI that would monitor the dialogue and provide suggestions for how to improve the conversation between the AI therapist and the user by just giving the AI therapist feedback in the background without the user knowing this. It's very similar to what we would do with the bug and ear technology. And what we
Mhm.
saw was a huge improvement in the amount of looping and also improvement in the quality of the Socratic dialogue that would shape as a result of this. So
Yeah.
that's really how the tool got started. Yeah.
That is such a really cool story, because what you've done is you've taken what is part of that LLM training process, which is that feedback, and you've brought it into the clinical environment and combined it with that supervision aspect, and really created this really unique process of giving the LLM feedback. And it sounds like it's helping it to improve. Tell me, from a clinical point of view, what is it that you actually are trying to get Socrates 2.0 to do? Like, from a clinical standpoint, what do we call success?
Yeah. Success is engaging a user in effective Socratic dialogue. So for us, right, it's basically changing cognitions that relate to someone's post-traumatic stress disorder specifically, but you could really apply it to any other cognitions that someone wants to work on as well. And
Hmm.
so we do this normally with worksheets and traditional therapy. And here it's just a much more engaging process of helping you explore evidence for, evidence against, other facts that may exist that you may have overlooked. And the LLM essentially helps you explore that so that you get a much broader picture of the struggles that you have, of the problems that you're currently facing, so that you can generate potential alternative beliefs that fit the reality a little bit better. And, as research has shown over the years, is that going through this process of cognitive restructuring facilitated via Socratic dialogue leads to then improvements in symptoms of PTSD, anxiety, depression, etc. And we've shown this in one of our feasibility studies that this tool can actually potentially get there.
Yeah, and I love that reference to research and studies, right? And one of the things that you've mentioned that I think is really important here is that we don't have clear benchmarks for what good enough is, right? Sometimes, so what does that look like? Not just for AI, but even for clinicians. What does that look like in practice, really?
I love this question. I think we could probably have a whole podcast just on that question alone. But so maybe let's start with AI, and also I think what we're doing in the AI space could actually translate in a very positive way to clinician training as well. So, like you
Hmm.
mentioned, there is no benchmark on what is really like good enough, and so we're fortunate for the specific skill of Socratic dialogue to have some existing ways of measuring this that have been used in clinical trials and others to measure the quality of Socratic dialogue. And now we're able to benchmark our tools against these existing validated scales to see whether the quality of dialogue improves by adding different agents or changing the functionality. So we have this benchmark. But ultimately what matters for us is the outcome. It's not so much the quality of the Socratic process, although that
Hmm.
is the but it's the outcome, is can we achieve symptom change? And there we are seeing some important signals, even in the early research that we have completed. So for us, that is the key outcome. But what's really nice is we're able to see what is leading to that outcome, and that is the quality of the process. Now, translating this to clinicians, like you asked, we don't have those same benchmarks. If we have study clinicians, we are able to evaluate pretty rigorously the quality of the Socratic dialogue or the quality of the therapy they're delivering, and we might be able to track outcomes similar to what we're doing with AI. But overall, as you know, most of the clinical sessions that we have with our patients are not recorded, they're not monitored, they're not scored. And so I think, what we're getting from the AI space is a lot of thought into how do we evaluate quality, not just in terms of the eventual outcomes, but also the closer outcomes that we have in terms of specific techniques. And I think until now, no one really spent too much time doing this because until now it required one of us to closely monitor, review sessions, spend a long time scoring them, giving feedback, etc. And we can now maybe take some of these newer tools that we're developing to also
Hmm.
automate that process, which I think will give clinicians an option to get feedback if they so choose, much more rapidly and in more real time, which I think ultimately will have really, really great impacts on improving the overall quality of the treatments we all deliver.
Yeah, I was talking to a group of clinical leaders last week, and one of the things that really came up from the conversation is we have done things in psychology a specific way for a really long time, and now AI is really forcing us to look at the way we've done things and ask the questions: Is that the best way? Is that the only way? Right? And so we're starting to think about how might we need to do things differently. What are some opportunities from a clinical perspective that we can take advantage of because of AI? And what does that require of us to do in terms of some introspection? So I'm wondering from a PTSD space, how has using AI really helped you to see perhaps different ways of doing things or things that we might need to look at in terms of how we do things?
Yeah, actually, some feedback we got from the users of our tool was that for PTSD, sometimes depending on the topic that we're focusing on or the type of trauma, there's a lot of shame involved, a lot of fear of judgment that individuals have when disclosing this. And so, from the AI space, what we've seen is then when individuals used Socrates, they oftentimes didn't intend to use it as a replacement for working with their therapist as well, but it helped kind of, I guess, a good way to describe is to lubricate the process. They were able to sort of like grease the wheels a little bit, practice what they were going to say, and also in the sense for practicing to see what is the likely response I'm going to get from my therapist. If I'm disclosing something, maybe that is related to a moral injury, things that I did in war that I shouldn't have done, that is, usually being judged by others. If I were to disclose this, and I'm disclosing this right now to this tool, what is the response I'm getting back? So I can, sort of form my own idea of, like, if I were to disclose this to Ernest in therapy, what am I gonna get back as a response? And so I think this is also a really interesting use case of AI, is that people may not view it as a replacement for therapy, because all of the veterans explained that they valued the relationship with the therapist that they had, but really as a practice ground to see, right,
Mm-hmm.
can I begin to work on shifting my thinking around really difficult topics, and also what would happen if I were to disclose this to an actual human therapist as sort of a practice ground almost, which I think might also facilitate the speed with which we can deliver therapy, because people have had all of these experiences already in an AI format.
Pre-processed. Yeah. I've heard many examples of where clients will work with an LLM prior to getting in the session, whether they will sort of do that pre-work so that when
Yep.
they get into the session, they can actually go deeper, right? Because it's a lot of the times you hear the client say, just as we're really get into the meat of stuff, our time's up, right? And so they do some of that pre-work and then they bring it into the session and say, here's the pre-work I've done. Can we go deeper? So I think that is a different perspective and a different way of doing things that we're not used to, that we might have to adapt to. What kind of response are you getting from the veterans in terms of their willingness to use this tool or their resistance to it? How are they feeling about it?
Yeah, surprisingly open to it. And I think this is something we didn't expect. So the vast majority of individuals who come to our program when we ran those trials were very interested in trying these tools.
Mhm.
Now, interest in trying these tools and actually trying these tools are two different things. And I think that's important to note, is that while individuals express interest, not everybody ends up using it. The
Mhm.
people who did use it found it extremely helpful, thought of it as more advanced than what they would have expected from something like ChatGPT, Gemini, Claude, you name it.
Mhm.
But people were extremely open in using it in a way to help with their treatment, essentially. And when we tested as part of the feasibility study, people didn't necessarily have to be in ongoing intensive treatment with us. So they could use it however they wanted to for a month. And so people used it fairly regularly during that month and experienced some benefit. But the way they interacted with it differed quite a bit by person, with some individuals being really willing to dive deep into pretty detailed traumatic experiences, whereas others chose to test it out a little bit at first with
Mhm.
less difficult topics, just to see what sort of responses you get. And maybe that's a little bit like testing the waters with a human therapist, where you try out a few things, see how your therapist responds, and then dive into this. But overall, individuals were very open to it, and to our surprise, also very few individuals had concerns about privacy, and potentially that is due to us doing an informed consent process where we went over privacy limitations and how the system was designed. But that was something that really surprised us, because when we think about AI on our team's end, privacy is always at the forefront of it. And so we thought it was going to be the same for our users, but maybe it was implied in the informed consent, or maybe it is just not as much of concern as we thought among individuals. But it doesn't mean the teams don't need to focus on it, obviously.
Yeah. You know what? When you're talking, what's coming to mind is that trust, right? There's an element of trust that comes in here. So I'm wondering if it's the trust that they have in you prior to you introducing the tool for them to use, or if they're just trusting the tool much more quickly. And so I know a lot of that comes up with what you mentioned in terms of proper use and validation, right? So talk to us a little bit about why it's important to validate these tools, how that is a really difficult problem, and how you guys are going about doing that to make sure that these things are valid and can be trusted by the users.
Yeah, I think you bring up a really good point, because I think important to note here is that this is not a tool that's widely available on the internet that anyone can use, right? It's always used as part of our treatment program, the Road Home
Hmm.
program at Rush. So it's affiliated with the university. I think maybe that's what helps individuals have initial trust in it. And then we do talk about some of the validation that we've done, which is pretty extensive upfront. So we've gone through thousands and thousands of dialogues that we have created, as well as that user groups have created for us, and we've evaluated those for potentially risky interactions. And so when we talk about potentially risky interactions, that is both on the user end, right? Does the user disclose something and can we detect it? But also, more importantly, does the AI spit something out that we would consider risky? And so we're looking for self-harm, other harm, but also inappropriate therapist behaviors, of aggressive behaviors, flirtatious behaviors, anything we would really not want to see as part of therapy. And so what we've been able to do using this multi-agent structure is we've been able to discover less than 1% of the scenarios had a risky behavior in it, even when we explicitly tried to get it off track, so to speak. And really saw that improvement by adding these different agents that all had essentially multiple sets of digital eyes on the topic. And layering all these safety features on top of one another is extremely important to us. And so we spend extensive amounts of time on this upfront before we ever put this in front of any of our study participants. We've actually turned this into another safety testing tool that we're now building on the back end of all of our other AI programs that we have, because we view this sort of like safety element as critical. And this is going beyond just as a user, expressing suicidal thoughts or other things, but it's really about the quality of therapy, because I think even there things can go off track quite a bit, because we don't want racist, sexist comments. We want to make sure that the quality of the responses is extremely high, and we can only achieve this by testing this in a number of different scenarios and by tapping into user groups with specific experiences that can help us test those specific scenarios. And then on top of this is sort of like looking at the quality element of it. But on top of this, we've worked really closely with Rush's cybersecurity team, their legal teams, and more importantly, an external team that validated the safety of the tool from a platform perspective. So this goes beyond just what is the actual output of the model itself, but this is going at how safe is this tool when used as a web tool. And so having these external teams all tested gives us a lot of confidence in what the tool can and cannot do and its limitations. And we're very clear about all of this with the users that are participating with us.
Yeah, I love this multi-agent approach. It really sounds like it gives a greater capability and also gives you the opportunity to really continue to fine-tune the tool. Talk to us a little bit about given the multi-agent approach where it really makes this tool much more capable. What, in your opinion, still remains clearly the responsibility of the clinician? So what is the tool? What are the boundaries for what the tool can and should be doing versus what clinicians should be doing?
Yeah, many things still, almost all fall still on the clinician. I would view the tool currently really just as maybe another way of completing what we normally would have done via a worksheet. So it's not replacing therapy as such. It's replacing a very specific element of therapy, which is you're maybe having a specific thought that you would normally work through on a worksheet on your own, but here you would work with this AI tool on your own. The responsibility of the clinician currently still is figuring out what are the appropriate treatment targets. So what are specific maladaptive beliefs we might want to target, helping patients prioritize what those targets are, in which order to address them, maybe identify other factors of risk, and even with conversations themselves, right? Just like we would do with a worksheet, it's the clinician's responsibility to review all of this. Now, as a clinician, it's easier to review a worksheet or a few worksheets that a client might give you because they're fairly easy to scan through. It's much harder to do this with a full-on conversation, and this is why we have some summary features and some risk flags and other things that help with this process. But ultimately, that is still on the provider to make sure they review, they monitor, and they're aware of all those different steps, no matter how many agents you have. And I think maybe important also to share here is that we developed this tool in a very specific manner that it replicates one specific therapeutic skill, Socratic dialogue. And that is because we have much more control over it in a way that we can test it. So if we had it function in multiple capabilities, right, Socratic dialogue, behavioral activation, you name it, then we would have to test each and every scenario for each and every one of these modalities. And if it were to switch back and forth, there's too many combinations for us to reasonably test and feel confident in. And so this is why purposely we limit it to only this one specific function that it completes for us, because it makes our work testing this tool easier, And it also makes the work on the clinicians a lot easier because they know that this tool can only be used for this one particular thing. So I have to, right, only focus on this one element when reviewing my patient's responses, essentially.
Mhm. So it's really functioning very purely as a tool there that's within the tool set of the clinician. I'm wondering how clinicians have responded to this, because sometimes clinicians may be concerned that it might take their jobs or have to deal with new technology. And so
Yeah.
what have been some of the responses that you've gotten from
all,
clinicians?
all of what you just described. But it varies quite a bit. So I think initially when we introduced this tool to our clinicians, there was this fear of like, oh God, here are the robots. Like how long until, I have to vacate my job and they're going to take over. And ultimately that's not it, because once they use the tool, they're like, oh, it just does Socratic dialogue. And it
Hmm.
essentially facilitates exactly the process we're trying to get people to do on worksheets that they're, not rebelling against, but that they're a little hesitant to do because it's just less fun. And so they started really engaging with it. And I think what the coolest thing was is that as soon as we gave this tool to our clinicians to play with, what we noticed is that they automatically, without us instructing them, started to role play their own patients to say, let me pretend to be Ernest right now and go through this just so I get some ideas for what Socratic questions could I be asking my patient in my
Hmm.
next session with them, and sort of like help maybe get them unstuck. And so I think that was a really neat use case of this that wasn't intended at all. But
Yeah.
it's sort of like these tools, even if they're developed for a different purpose, can have really, really positive implications for the training process or for helping advance our work with our patients. So yeah, all of these tools were never intended to replace therapy. It's just replace a part of therapy that we found users to not engage with very well. Yeah.
Mhm. Yeah, I love that insight that the clinicians were able to see that, hey, this can actually be really helpful to me even, right, to help me increase my understanding and my abilities with the client. I'm wondering in terms of from that perspective, what other uses could we be seeing in the future here, in terms of helping it improve clinician performance, helping it in terms of supervision. You use the supervision analogy. What do you see as future applications of a tool like this or this specific tool even?
Yeah, so we've moved into the training space a little bit. We've worked closely with Face the Fight, that is funding us to develop a training version of this tool.
Mhm.
Exactly this example that I just described, right? Based on this feedback, the question is, can we use this as a way for people to practice, not just by role playing their patients, but also potentially working with AI-based patients and getting
Mhm.
real-time feedback from these multiple different agents, so getting different type of supervisory feedback to help them improve working with different kind of presenting concerns that they may be faced with, but it's oftentimes really difficult to practice or prepare for. And I think that's really where I see, aside from the direct to patient world, where I see a lot of applications for these types of tools. Because when we think about how a lot of our trainings are in psychology, is we attend a workshop, and as part of this workshop we role play with some of our peers, and both of us are still learning certain skills. And
Mhm.
oftentimes the facilitator has to manage 30 to 50 people in a workshop, so the feedback we're going to get is relatively minimal. And we also know that some of the time we end up talking about how our weekend was or what we do for work rather than actually practicing the actual skills we're supposed to practice. And so I think having platforms like this to give individuals the opportunity to practice in a safe space, getting real-time feedback that has been validated by experts in the specific fields, can be another good way of bridging the gap between learning a skill and actually applying this in a real world higher pressure setting with an actual patient. And so, I don't know if we'll ever get there with training programs. I assume we will one day, but especially for trainees, this can be a wonderful opportunity to just try different things. And also, you can't harm an AI patient. So if I wanted to see, well, if I were to say this instead of that, what would happen with the session? Like, we can't try this with human patients. So we need these practice grounds. And I think from a learning perspective, that can be really insightful for a lot of trainees to be able to not have to worry about, am I going to mess something up, and just really practice, get feedback, use that feedback, and then see, can you improve maybe with the same type of patient the next time you practice with them, AI patient I should say, the next time you practice with them. Yeah.
Yeah, I love this future oriented of what could be in the future. I'm wondering about, with all of these AI applications and the potential for all of these great advancements, what are some of the things that we need to do first in terms of benchmarks, for example, in terms of human clinicians? What kind of benchmarks do we need? And then boundaries. What kind of boundaries do we need to identify for where AI should be and shouldn't be?
Yeah, great question. So for I think benchmarks are numerous ones in different ways. So we talked earlier as part of our conversation about what is the intention of the specific tool. So I think we need to be clear about what a specific tool is intended to do and figure out how do we measure whether it's actually doing this. And even there, within that, think we have the eventual outcome. In our example, it might be reducing PTSD severity, but we also have these sort of like intermediate steps of is it doing what we want it to do? So in our case, is it actually facilitating a Socratic dialogue? And is that Socratic dialogue actually leading to shifts in cognitions like we intend? And is that then leading to the outcomes that we hope it would lead to? And it's a very mechanistic view. And I think right now it's we're not quite there yet as a field, right? We're trying to mimic what we have tested in human based studies, but a lot of what these AI tools allow us to do is test things in this isolated way that we would never use as human therapists.
Mhm.
If you came to me, I wouldn't necessarily start a session by saying like, well, Ernest, what's a belief you want to work on? And then just fire away a bunch of Socratic questions over and over because it would feel unnatural. And yet we're able to create these artificial scenarios with AI, and humans seem to interact with it just fine because they're assuming this is what is intended to do. And so I think we're able to test very specific elements of therapy in a nuanced way that we otherwise wouldn't really be able to test as well in human to human interactions. And so
Yeah.
I think creating those benchmarks is going to be important. And then the more your AI tool tries to do, the more careful we need to be about, do we have the right benchmarks? Do we understand whether the AI tool is actually doing it? Um, and so I think this is where your question about guardrails comes in, is what guardrails are sufficient? And I think the answer, right, like the standard psychologist answer of it depends, applies here. Like we definitely need guardrails around safety and understanding what is appropriate safety detection, but also our field is very much struggling with, and then what? So do we just provide numbers to crisis lines? Do we create a direct link that opens up on the screen to crisis lines? What is appropriate? Can this also be discouraging to individuals who want to use a chatbot for maybe some more sensitive topics if they're always handed off to somewhere else? And so I think guardrails will very much depend on what the tool is intended to do, but I
Mhm.
think as a field, we're very much not there yet to know what are the best practices. I think, groups like APA and others, we're trying to think of best practice guidelines, but the technology is also advancing so fast that it's really hard to shape guidelines today that will still hold up in a year or 2 years from now, just because of how quickly the field is advancing.
I think that's one of the main problems that I notice is that the field is advancing really quickly and the scale is really large. And so it's really important that as we're figuring out how to identify boundaries and guidelines and things like that, they need to be flexible as well. Because as the field advances, the technology advances, the guidelines and the boundaries have to be flexible to adapt. What AI could do today is not what it could do yesterday, and what it could do tomorrow is not what it could do today. So really being flexible. What I really appreciate about the way that you guys have done this is I really consider it to be one of the responsible approach because you're validating it before you put it out, right? You're validating what it does and making sure that you understand sort of its boundaries before you're introducing it to the clients.
Yeah,
Philip, this
validate
that's great.
internally and externally, I think is the last thing here to share. And if I can add one last thing before we sort of like seem to be wrapping up here, is that when we just say we need to validate it, that can mean a lot of different things to a lot of different people. And so the part about guidelines, I think, or boundaries, we don't yet have a standard for how much validation is enough and who determines it's enough. And
Yeah.
right, like anyone can say we've validated it or clinical experts have validated it, but I think there's this big question of, well, what constitutes a clinical expert and how much
Yeah.
validation is enough. And you've reviewed 100 transcripts or 1,000 transcripts. Is that enough? Or,
Yeah.
right, like who determines this? And I think we as a field are just not there yet in thinking of it, because it's so very different than where we've ever been as a field. And I think that's exciting in a way.
Yeah, that's such a great point in terms of even something as basic as validation, right? Who determines what that looks like? Who determines what's enough? So that's a great place to start. So, Philip, thank you so much for coming on the show. This has been really a very interesting conversation. How do people contact you if they want to continue the conversation with you?
Yeah, I think people can reach me on LinkedIn, or they can find information about me on the Road Home Program website, which is roadhomeprogram.org, or look up my faculty profile at Rush University Medical Center.
Awesome. And what's a tip or recommendation that you can leave us with?
A tip or recommendation that I can leave you with. I think it's
Oh,
that when thinking about the future, just remembering how terrible we as humans are about predicting the future, and thinking of, like, I think most of us, when we think of AI and these technologies, we think of the current technologies that are in place.
mhm.
But like we just talked about, technologies are advancing so quickly. And right now we're thinking about large language models. And I think this is just pretty much the start. And so I think
Mhm.
that the best way to deal with this, that I found for myself, so this is my tip here, is to just be curious about the capabilities of these tools, and just sort of to learn alongside the new releases of these versions, try different tools, see what they can and can't do, and learn for yourself rather than just depend on other people to always tell you. So I think using that curiosity and being engaged in that field can alleviate some anxieties, can probably also steer up some anxieties, but at the very least, I think it creates an understanding of what these things that we have to deal with are capable of or not capable of. And I think it's a really, really exciting future for our field.
Yeah, I love that. Be curious, stay informed, and engage. I think those are really great points. Philip, again, thank you so much for coming on the show. It's been such a pleasure.
Yep, thanks for having me.
Awesome. And if you've enjoyed the show, please subscribe and leave us a review. Feedback is a gift, and we love gifts. We hope you'll join us again.